Hello viewers, good day to all of you. Today I am going to discuss about the radioulnar joints. Now, our learning objectives for today's lecture will be on. So, as usual for any joint, we discuss it under the following headings. First of all, what type of joint it is. Then what are the bones which take part in the joint? So mainly which part of the bone, to be more precise, that is the articulating surfaces, the ligaments involved in this joint which render support to the joint, relations of the joint. Then with respect to today's lecture on the superior radioulnar joint, we are going to see in detail about this movement, pronation and supination. Then applied anatomy. At the end, we will be actually completing it with the applied anatomy. Now, there are three radioulnar joints in the forearm: superior, middle and inferior radioulnar joints. The superior radioulnar joint is a synovial joint, so it has a capsule, synovial membrane is present, and also it is a part of the elbow joint, so it is going to share the capsule or the joint cavity with the elbow complex. The middle radioulnar joint is just the two bones. The shaft of the humerus and ulna is going to be connected with each other or held together by the interosseous membrane. So it is the fibers, mainly the collagen fibers, so it is a fibrous joint, also called as syndesmosis. So the main structure which is going to hold these is the interosseous membrane or ligament. You call it as a membrane because it is flat and stretched two out. More than a ligament, membrane would be a appropriate term. The inferior radioulnar joint, like the superior, is actually a synovial joint which has all the characters of the synovial joint. And again, what happens is it blends with the wrist joint. The capsule blends with the wrist joint, so naturally it shares the cavity with the wrist joint. But this is not even actually true, because here there is a cavity which is shared, but here it is not true, only the capsule blends. So now coming to the superior radioulnar joint, it is of synovial joint pivot. Okay, so what is a pivot joint? It is also an example of uniaxial joint. Movements are possible only in one plane. So coming to the articulating surfaces, the circumference of the head of the radius. Okay, the head of the radius is actually the whole thing, but only the circumference or the rim of the head of the radius takes part in the superior radioulnar joint, whereas this upper surface of the head is actually taking part in the elbow joint, that is humeroradial articulation. Only this part of the radius takes part in the radioulnar articulation. So when this forms one of the articulating surface, circumference of the head of the radius, then the remaining is formed by the radial notch, and what is attached to the anterior and posterior margins of the notch is again a fibrous structure which is called as the annular ligament. So here you are able to see the annular ligament. Part of the ligament has been removed for you to show the head of the radius. So the annular ligament, along with the what you saw here, the radial notch, forms a continuous ring which is called as the osseofibrous ring, because radial notch is bony and this is fibrous. The bony part contributes to the 1/5 of the ring, whereas the annular ligament or the fibrous part contributes for the 4/5 of the osseofibrous ring. So we all very well know that the articulating surfaces is covered by the hyaline cartilage or the articular cartilage. So in this case also the circumference of the head of the radius is covered by the articular cartilage. The interior of the annular ligament is also lined by articular cartilage. So that you should keep in mind. The ligament, inner aspect of the ligament is also lined by articular cartilage. Only then it can articulate, because that also forms the articulating surface, because the head is going to roll inside the osteofibrous ring during the movements of pronation and supination. So that is here you are able to see the osteofibrous ring. 4/5 is fibrous, 1/5 is bony, and they all are lined by the hyaline cartilage. If you look at the annular ligament, as you see come down, as it proceeds downwards, the lower end of the ligament is somewhat cup shaped. So it is actually cup shaped. Upper end is actually wider, but lower end, as you come slowly, what happens is descends and also it converges. Now why is because the head which is going to rotate inside this osteofibrous ring should not slip down. Okay, so that is why if it is uniform throughout from above downwards, the head might slip easily from this and dislocation might occur. So to prevent this and to actually give some support, what happens is it is somewhat cup shaped, and this ring is attached to the anterior and posterior margins of the radial notch. The upper border of the annular ligament will blend with the capsule of the elbow joint, and as I told you before itself, it is lined by hyaline cartilage. So here you are able to see the elbow joint capsule which is attached to the margins of the coronoid fossa, radial fossa, and origins of the your coronoid process, radius, and all those things. So this is your annular ligament, and if you look at the annular ligament, what happens is it blends above with the capsule of your elbow joint. So is that clear? So now we will pass on to one more ligament which is actually called as the quadrate ligament. So what is actually the quadrate ligament is, some of the fibers of the annular ligament more distally, what happens is they will cover the synovial membrane. So this is short recess. See, the synovial membrane lines the interior of the capsule. Okay. So after that, what happens is it might reflect onto the bones also. So it reflects onto the radial neck, this part. It is reflecting onto the radial neck. But remember, synovial membrane will not line the articular cartilage. So articular surfaces will be covered by articular cartilage, and this articular cartilage will not be lined by synovial membrane, because if it is lining the synovial membrane is lining the articular cartilage, then the membrane will get ruptured when that articulation takes place in that joint. Okay. So few fibers of the annular ligament covers the synovial membrane near to the radial neck. So it is actually giving some support from below to the synovial membrane, and it is closing the joint inferiorly. So more chances of the joint getting dislocated inferiorly. So these are all some of the reinforcement mechanisms. So here you are able to see the cavity of the elbow opened. So it is a common joint cavity both for the elbow as well as the superior radioulnar joint. Anterior view, where you actually see the trochlea and the capitulum. This is actually the coronoid process of the ulna, and this is the head of the radius. This is the radial notch of the ulna. Posteriorly again you are able to see it is attached, capsule is attached to the margins of the olecranon process and olecranon fossa, margins of olecranon fossa, olecranon process. You are able to see neck of the radius, and this is the coronoid process. Okay. So It shares a common joint cavity with the elbow joint, that is the superior radioulnar joint. So interiorly, capsule is lined by synovial membrane and it is continuous with the elbow joint. Now coming to the relations, mainly it is related to the laterally, it will be related to the radial collateral ligament and supinator fibers anteriorly and laterally. So here supinator fibers. Posteriorly, here you will have the fibers of anconeus. Anconeus muscle forms the posterior relation for the superior radioulnar joint. So now supply branches from the median nerve. We will give articular branches before passing through the pronator arteries. Then articular branches from ulnar as well as the articular branches from the radial nerve. So we have seen about the superior radioulnar joint, pivot joint, synovial joint, capsule blends with the capsule of the elbow joint. The ligaments are mainly the annular ligament and one more small ligament. What we have seen is the quadrate ligament. Now coming to the middle radioulnar joint. So here you are able to see the middle radioulnar joint. It is of fibrous type. Syndesmosis is fibrous joint. Or next you call it as synchondrosis, which is primary cartilaginous, and then you have symphysis, which is secondary cartilaginous joint. Syndesmosis. So here you are able to see this is the middle radioulnar joint. The interosseous border of the two bones are held together by the interosseous membrane. Because it is present between the two bones, it is called as interosseous. So as I told you, the articulating surfaces will be the interosseous border of the radius, which is the medial border for the radius, and interosseous border of ulna, which is again the lateral border for the ulna. The next ligaments, coming to the ligaments, first we will start from above downwards, the oblique cord. So here you are able to see an oblique cord is more or less like your interosseous membrane, only made up of fibers, collagen fibers, considered as a remnant of flexor pollicis longus muscle and extends from the ulnar tuberosity to the radial tuberosity. It extends from the ulnar tuberosity to the radial tuberosity, and the fibers run downwards and laterally. So the fibers, they run downwards and laterally from the ulnar tuberosity to the radial tuberosity. And if you look at the direction of the fibers, as I told you, they run downwards and laterally. It is at right angles to the fibers of interosseous membrane. So see, they are perpendicular to each other. Okay. So fibers of the oblique cord, they run downwards and laterally, extending from the radial tuberosity to the ulnar tuberosity, from ulnar tuberosity to the radial tuberosity. So that is the oblique cord for you. The next we are going to see about this is the interosseous membrane. The interosseous membrane is a sheet, a fibrous sheet between the interosseous border of radius and ulna. Now, between the oblique cord and the upper border of interosseous membrane, there is a gap which is somewhat triangular in shape, which is going to transmit the interosseous artery, that is the posterior interosseous vessels and nerves. Okay. Same way, near the lower border also there is again a gap near to the lower end of the interosseous membrane, through which the anterior interosseous vessels, they will pass backwards. Here posterior interosseous vessels, here anterior interosseous vessel. If you look at the interosseous membrane, inferiorly it blends with the inferior radioulnar joints capsule. Okay, the interosseous membrane inferiorly blends with the capsule of inferior radioulnar joint. So as I told you, there is a small gap in the lower part of the interosseous membrane for the passage of the anterior interosseous vessels. Now, coming to the interosseous membrane as such, if you look, the fibers pass downwards and medially. So, you are able to see the fibers are passing downwards and medially. Again, this is not completely true or does not apply for the whole of the interosseous membrane. Again, you are able to see here the lower part of the fibers, they again are in reverse direction. It passes upwards and laterally. So, it is reversed in the lower part. Now, why actually it is so? Upper part you have one direction, but the lowermost fibers are in the reverse direction is because when there is a transmission of or any impact to the two bones, then naturally what happens is that impact has to be transmitted to the humerus. That is why. So, withstand the forces of transmission. If it is in one plane, then naturally what happens is the membrane might give away based on the impact of the force. To withstand it, when it is reinforced in a zigzag manner, almost when you see upper part and the lower part, then naturally what happens is the weight is transmitted equally or it is distributed. Now, if you look at the interosseous membrane during your movements of pronation and supination, in the mid-prone position, the interosseous membrane is very tensed, whereas in cases of extreme pronation or complete pronation, or in case of complete supination, the interosseous membrane is lax or it is in a relaxed position. So, because in the mid-prone position actually it is tensed, so when we make a fist and want to give a blow to somebody, we keep our forearm in a mid-prone position. So, that is when you want to box. So, the boxers you would have seen, or you when you want to box, somebody punch somebody, you keep your forearm in the mid-prone position. So, in this position, the interosseous membrane is in a very laxed manner, very tensed, it is in a tensed position. Now, coming to the relations of the middle radioulnar joint. So, this part is the middle radioulnar joint. So, naturally it will be related to your deep flexors, flexor pollicis longus, flexor digitorum superficialis, and more inferiorly the pronator quadratus. Posterior relations of the middle radioulnar joints consist of your abductor pollicis longus, extensor pollicis longus, and brevis. Okay. So, posterior abductor pollicis longus, extensor pollicis longus, and brevis with its posterior interosseal vessels and nerves. Coming to the inferior radioulnar joint. Okay. So, now we are going to discuss about the inferior radioulnar joint. Middle radioulnar joint is a fibrous joint, syndesmosis variety. This is a synovial joint, again uniaxial pivot type. Okay. So, it is a uniaxial variety. So, articulating surfaces, the lower end of the ulna is actually called as the head, which is very small. The lower end of ulna is small. The head, usually we see in the long bone, the head is at the upper end, but here in ulna you see the lower end is round. That is why it is called as head. And more medially you see this is actually the styloid process. Then you also look at the inferior end of both the ulna and the radius. Both are not lying at the same level. Now, the lower end of the radius is massive as compared to the upper end, and you have a styloid process which is almost thick and stout than the styloid process of ulna, and the styloid process is almost at a lower level as compared to that of the styloid process of ulna. So, that is the inferior radioulnar joint for you. The articulating surfaces are formed by the head of the ulna, and laterally you have the ulnar notch of the radius. Both of these are actually covered by the articular cartilage, and it is invested by the capsule, encloses the articular surfaces, and interior of the capsule will be lined by the synovial membrane. Interior of the capsule will be lined by synovial membrane. Again, the capsule blends with the wrist joint. But remember, it does not share a common cavity with the wrist joint. Wrist joint is again closed inferiorly. Okay. So, inferiorly the radioulnar joint does not communicate with the wrist joint. If you look at the synovial membrane, there is an outpocketing or extension of the synovial membrane which is called as the recessus sacciformis. It is an upward prolongation and it is present between or deep to here you have the pronator quadratus muscle. So, anteriorly you have the pronator quadratus muscle and posteriorly you see the interosseous membrane. So, it is lying between the pronator quadratus muscle and the interosseous membrane. An extension of the synovial membrane which is called as the recessus sacciformis. So, you are able to see the inferior view of the radius and ulna. So, here the inferior surface of head of the radius, this is the head of the ulna, this is the inferior surface of the radius, both are actually covered by articular cartilage. So, this is actually for the wrist joint. Inferior radioulnar joint you see here, that is the inferior radioulnar joint between the head of the radius and the ulnar notch of the radius. Ulnar notch will be seen here. So, you have an articular disc or intra-articular disc you call it, which separates the cavity from the wrist joint. So, the apex is attached to a depression between the head and the styloid process. It's triangular in shape, the intra-articular disc. It is attached to the depression between the head and the styloid process, the apex. Base is actually between the ulnar notch and the carpal articular surface of radius. So, ulnar notch and carpal articular surface of the radius. Okay. So, that is the attachments of the articular disc. So, above the disc what happens is rotary movements in case of the pronation and supination takes place in the inferior radioulnar joints. Below the disc it actually permits angular movements of the wrist joint. Okay. So, below the disc it is going to perform angular movements such as your flexion, extension, adduction and abduction. Above the wrist it is going to perform rotary movements. Anywhere you come across a disc in the joint, intra-articular disc, so definitely it is mainly to divide the joint compartment into an upper compartment and a lower compartment. Upper compartment will actually form rotary movements or gliding movements, vice versa, whether it is above rotary, below gliding, or below rotary and above gliding movements. So, that is about the articular disc concerned with the inferior radioulnar joint. Okay. Now, we will come to the most important aspect of today's lecture, that is the movements concerned with the radioulnar joint. In the radioulnar joint, the movement concerned are pronation and supination. So, the axis of movement is actually oblique axis. It is not a straight axis or it is not a transverse axis. It is an oblique axis which is running from the center of head of radius. So, it runs from the center of head of radius to the styloid process of ulna. So, here you are able to see from the center of head of radius to the styloid process of ulna, what happens is the axis of the radioulnar joint. When you prolong it more, it goes to the little finger. When you prolong it, it actually goes to the little finger. Then the axis is itself not a constant axis. Upper part, it is always the center of head of radius. There is no change in the axis during all movements of the pronation and supination. But in the lower part, what happens is, as you pronate and supinate, the axis shifts from little finger. In case of supination, it might shift from here to the ring, middle finger, and the index finger. Okay, so the axis keeps on shifting in the lower end. Okay, so the range of movement of pronation and supination in a flexed or semi-flexed elbow. Flexed elbow you cannot perform completely flexed. Semi-flexed elbow, it is 140 degrees to 150 degrees. Okay, 140 to 150 degrees is the axis of pronation and supination. Up to 150 degrees it can pronate or supinate. In an extended elbow, that is when the arm is at the hanging by the side of your body in the anatomical position, then it is 360 degrees. So that means one complete full circle it can do, but with associated movements of the humerus. Okay, so with the associated movements of the humerus, it can perform 360 degrees, because medial and lateral rotation of the humerus is also going to take place along with pronation and supination in an extended elbow. So that is why when you want to test mainly the pronation, not the pronation, medial and lateral rotation of the humerus, you should test with the patient asking him to semi-flex the elbow. Half flexed elbow, you should test the medial and lateral rotation of humerus. If you ask him to do rotation in an extended elbow, you don't know whether the humerus is rotating or whether the pronation and supination action is actually mimicking the rotation of the humerus. Okay, so once again I repeat, the axis starts from the center of the head of the radius and passes downwards and medially to the ulnar styloid process and extending to the middle finger. It is not fixed, it gets shifts as you move laterally or medially. So coming to how the pronation takes place. So radius, what happens is, in the superior radioulnar joint, it is going to rotate, the head of the radius is going to rotate. The radius carries itself. So this dotted line is the original position. From there, it carries the hand moves anteriorly and laterally. Okay, the hand moves anteriorly and laterally, crosses the ulna obliquely. The radius crosses the ulna obliquely. Proximal end, no change, it is lateral to the ulna only. In the middle, it actually lies anterior to the ulna, but in the distal end, it crosses the ulna to come to the medial side. Okay, so upper end, there is no change, it is lateral. Middle radioulnar joint, you are able to see the interosseous membrane twists, and naturally it is coming to lie here on top of the ulna. Lower end, you see the lower end of the radius crosses the lower end of ulna and comes to lie medially in pronation. So superior radioulnar joint, the head of the radius rotates inside the annular ligament or osteofibrous ring. In the middle radioulnar joint, you see here the radius crosses the ulna forward and medially. Overlapping takes place. In the inferior radioulnar joint, the lower end of the radius has completely come to lie medial to the ulna, carrying the hand with it. Okay, so that is the three changes which is taking place in the superior radioulnar joint, in the middle radioulnar joint, and in the inferior radioulnar joint. The upper end it rotates, in the middle part it is crossing obliquely, and the lower part it has crossed and come to lie medial. Now, ulna, in all the descriptive movements, as I told you in pronation, it appears as if the ulna is stationary. Only radius is taking part, all the changes are taking place radius. It appears so, but actually it is not stationary. Ulna, what happens is, during the act of pronation, it moves backwards and laterally. So that is why again the axis also keeps changing in the lower end of the superior radioulnar movements. Sorry, in the lower end of the radioulnar movements, that is pronation and supination. Okay, during pronation, the lower end of ulna moves backwards and laterally, and in the reverse of the pronation, that is the supination, again the ulna moves forwards and medially. The ulna moves forwards and medially. Okay. Now coming to the supination, so it is the reverse of pronation, you see here, thereby it comes to lie side by side, radius and ulna. It is a powerful anti-gravity movement. Are you able to understand? It is actually a powerful anti-gravity movement. That is why against the gravity, compared to the pronation, the supination performs against the gravity, and it is mainly performed by the biceps brachii muscle. So ulna returns laterally, radius returns lateral, ulna moves anteromedial and distal. Okay, somewhat slightly downwards. In pronation, it moves proximal or slightly upwards, the lower end of the ulna. So the muscles producing the movements are pronator teres and pronator quadratus for the pronation, and it will be assisted by flexor carpi radialis to some extent. Supination will be formed by the biceps brachii, powerful supinator, especially in a semi-flexed elbow. Okay, so that is why these biceps are very powerful supinator. All your screwing movements of the hand, you do it mainly in the semi-flexed position. The biceps brachii can act very effectively. The other muscle supporting the supination is the supinator muscle, which you see here along the upper part of the shaft of the radius. Nerve supplies by anterior and posterior interosseous nerve. Pronator teres, pronator quadratus will be supplied by the anterior interosseous nerve. Posterior interosseous nerve supplies the supinator muscle. So the spinal segments involved is the C6, C7 and C8 cervical segments are involved in the act of nerve supply, innervation. These segments of the spinal cord are involved. Okay, so here you are able to see the supination is mainly brought about by the supinator muscle. Biceps actually is not shown here. In pronation, the crossing takes place, and it is mainly brought about by your pronator quadratus and pronator teres. Okay, so far we have seen about the construction of the superior, inferior and middle radioulnar joints. Then we have described about the pronation and supination. Now suppose if you get a question, describe pronation and supination, means you have to write mainly what is the definition for a pronation. Pronation is what? When the palm of the hand faces downwards. When the palm of the hand faces upwards, it is actually called as supination. This is in case of semi-flexed elbow. In the normal anatomical position, when the palm faces anteriorly, it is supination, and when the palm faces posteriorly, it is pronation. Then next you have to write about the axis, from where to where, extension from the center of head of radius passes downwards and medially to the styloid process of ulna. Then you have to describe about the movements which is taking place at the superior radioulnar joint, movements taking place at the middle radioulnar joint, and movements taking place at the inferior radioulnar joint. So above it rotates, here the shaft overlaps, interosseous membrane is becoming tensed, lower part, the radius crosses the lower part of ulna and comes to lie medially. Then you have to mention about the movements of the ulna. It is not stationary, it moves proximally and medially in the pronation, in the supination. In pronation, it moves backwards and laterally. Okay. If they ask about superior radioulnar joint, then you have to describe about this ligaments capsule of these three joints, and again you have to describe about the pronation and supination movement. So both the supination and pronation movement and the superior and inferior or the radioulnar joints, they are interrelated, because movements takes place at this joint. Okay. Now coming to the applied aspects, the most common thing is called as the pulled elbow, seen in children under 6 years of age. Why 6 years of age? Is because the head of the radius, epiphysis, is not completely formed, so there is a chance of the head of the radius slipping out of the annular ligament. So that is called as pulled elbow. When it happens, when you try to lift a child or grab the child by the forearm. So that is why you should hold the child at the arm or at the axilla region, but not here. Then what happens? The elbow gets pulled. So dislocation of the radius due to sudden traction of wrist, especially in the wrist region. So here you see it has come down slightly. This is subclinical. It can be reduced without much invasive intervention. So if you go, the physician will actually reduce this subclinical subluxation. The next, what happens is the whole of the head of the radius has come out. This is actually called as a subluxation, means dislocation. Okay. Then complete dislocation, you see here, it is not only slipped out of the annular ligament, but it comes to lie outside and laterally. Okay. So one is subclinical, one is clinical subluxation, and other one is complete dislocation. Pulled elbow, this is called as the pulled elbow. Next, coming to the fractures of the lower end of the radius and the lower end of the ulna. So in case of Colles fracture, so here you are able to see, in case of the Colles fracture, the lower end of the radius is displaced and there is a posterior angulation which represents a dinner fork. So that is why it is called as a dinner fork deformity. So fracture of distal end of radius with the dorsal or posterior angulation. The opposite of Colles fracture is the Smith fracture, where the fracture of the distal end of radius and it is displaced ventrally. So here you are able to see it, distal end has moved ventrally. There is no dorsal angulation but only ventral displacement. That is actually called as the Smith's fracture. So one is the Colles fracture and the reverse of the Colles fracture is the Smith's fracture. Now generally when you look at the fractures of the radius in the upper part, if it is going to take place proximal to the insertion of the pronator teres, so before the insertion of pronator teres, then what happens is, above the insertion of pronator teres, the proximal end will be flexed. There is flexion because of the pull of this biceps tendon, and the distal end is pronated because the pronator teres and the quadratus is unopposed. It pulls the distal segment. So there is pronation at the distal end, flexion at the upper end. Now if again there is a fracture after the insertion of the pronator teres, somewhere in the middle of the radius, then the upper end is neutral. Okay, the upper end is neutral because pronation, supinate or both are actually intact. So naturally it will be the neutral position. But lower end, what happens is, due to the action of the pronator quadratus, it gets pronated. So whether above the pronator teres or below the pronator teres, the lower end is getting pronated, but the upper end is flexed in case of the first type when it is above the insertion of pronator teres. But below the insertion of pronator teres, if there is a fracture, then the upper end lies in a neutral position. Okay. The next, coming to the two other types of fractures, one is Montigia fracture, fracture of ulna. So far we have seen about the fracture of radius, that is Colles fracture with the dorsal angulation, dinner fork deformity. Smith's fracture is the reverse of the Colles fracture, where there is ventral displacement of the lower end of the radius. Okay. Now coming to the Montigia fracture, it is fracture of ulna and dislocation of superior radioulnar joint. The other one is Galeazia fracture, whereas the fracture of radius and dislocation of inferior radioulnar joint. Okay, so only thing you should be used with these terms, what is Montigia and what is Galeazia, but both are actually fractures of the ulna. In one case, superior radioulnar joint is dislocated, in other case the inferior radioulnar joint is dislocated. So finally, we will have a look at the radiograph of the elbow and the wrist. So here you are able to see the lower end of the humerus, that is the medial condyle, and that should be the lateral condyle. Here you are able to see the trochlea, and here you are able to see the capitulum. Circumference of the head, this is neck of the radius, radial tuberosity. This is actually the coronoid process of ulna. This is coronoid process of ulna. This is actually the notch, radial notch of the ulna, radial notch. This is the trochlea, medial flange of the trochlea you are able to see here. This is the olecranon fossa in which olecranon process is superimposed. Okay, so that should be your ulnar tuberosity. Coming to the wrist, lower end of the radius with the styloid process, head of the ulna with the styloid process, inferior radioulnar joint. This is actually the ulnar notch for the radius, ulnar notch of the radius. These are the carpal bones you see here. This is proximal row of carpal bones and this is the distal row of the carpal bones. Scaphoid, okay, lunate, scaphoid, lunate, 9 is triquetral, 10 is pisiform. So pisiform is a round P shape which is seen on top of triquetral. Scaphoid, lunate, triquetral and pisiform. Then again you should start from here. Trapezium, trapezioid, capitate with a large head-like structure. 3 and 4 is actually the capitate. 5 and 6 is the hamate. 5 is the hamate. 6 is actually the hook of the hamate. Then you see the 5 metacarpal bones. Okay, so this is actually the 5 metacarpals. First one is the shortest and the stoutest of all the metacarpals. So thank you very much for patiently listening to this lecture. We will meet again in one more lecture shortly.